Casey Copeland is a peer recovery peer supervisor and the director of Exodus.life, which is a nonprofit organization that uses a faith-based approach to address addiction, co-occurring diagnosis, and helps incarcerated individuals reintegrate back into their communities. Casey, awarded Supervisor of the Year in 2021 and 2022, has been engraved in the Arkansas model of peer recovery since its inception, serving on multiple boards and committees, including Director of Arkansas Peers Achieving Recovery Together, Director of Rock of Hope Transitional Houses, and a regional member of the Arkansas Peer Advisory Committee. Casey continues to play an intricate role in the development and implementation of multiple programs across the state. Born and raised in Little Rock, Arkansas, Casey graduated from Central High School. He then attended the University of Arkansas at Little Rock. After spending nearly a decade in the insurance business, he found himself suppressing his deep-rooted grief after losing his father. By the age of 27, he was diagnosed as having clinical depression and was prescribed medication, which he began abusing. Over time, this led to him using much harder drugs and resulted in his incarceration. Casey is a person in long-term recovery since 2017 and spent his first year in recovery volunteering at multiple organizations in Central Arkansas. Once clean from drugs and alcohol, he met and married his beautiful wife, Megan. Their daughter, Adilynn, was born in 2020. Casey continues to put God first in everything that he does and gives God all the glory. He continually strives to stay focused on his recovery by working a program. When he is not working, he enjoys spending time with family and friends. Casey Copeland is one of the 10 original peer supervisors in the state of Arkansas. He now supervises multiple peer in trainings, advanced peer in trainings, and supervisor in trainings all across the state of Arkansas. He is the first peer recovery specialist supervisor in the state to hold a position in a jail setting, helping develop and implement the PAC program at the Lonoke County Sheriff's Office. He is also a trainer of trainers for the Arkansas Model and Via Hope Reentry Program. We are so fortunate to be able to add him to the conference lineup this year. So, without further ado, Mr. Copeland.
Thank you, Misty, and thank you, Artificial Intelligence, for writing that great biography for me. So, yes, my name is Casey Copeland. I'm very excited to be here. I'm excited to share with y'all something that I have invested a ton of my time in. It is where I find a lot of purpose in my life, and it also pays my bills. And as you can hear, my life is perpetually out of balance. I love to serve people. I feel like that is my purpose in life, and that's what I'm going to do with the rest of my life. So I'm going to take you guys through some programs that I was involved in since the inception of them, and I'm going to elaborate on the ones that I've been a part of since they started. And then we're going to kind of transition after I go over the learning objectives. We're going to transition from that into the coalition and what our efforts are with ABEN. And I'm going to bring up some of my team members. As y'all already know, they've introduced my beautiful wife up here, which is good for y'all because she won't let me go down any rabbit trails. She'll keep me on track here, okay? All right. So the learning objectives is to understand what a peer recovery specialist is, pathways to becoming a peer recovery specialist, Arkansas law concerning peer recovery specialists, and innovative peer recovery programs in Arkansas. So question, what is a peer specialist? Does anybody know what a peer specialist is? Besides you three back there and y'all in the front row. What you got?
My daughter's a peer specialist. It's someone with a lived experience of addiction that goes into spaces and supports people that are in like recovery programs and just kind of walks alongside them.
Okay, that's good. So what a lot of people, sometimes I think they misunderstand that because we are in long-term recovery. Is that me? If it keeps up, I'll just turn this off because I can talk loud as it is. But just because we're people in long-term recovery, that does not make us peer specialists. A lot of people say, well, I've been a peer specialist for years because I sponsor people. That's not what we do. What makes us a peer specialist is the lived experience we have, but it's also coupled with some extensive training and a code of ethics that we sign that we're bound by. So lived experience plus training, like I said, gives us the ability to identify. If you're working this business, you clearly got a passion for wanting to help people. Bound by ethics. Professional development is something that we continue to strive to do. It's also part of our ethics. Continued training and the instant rapport that we build just from what we've gone through. It's like you hear a lot of people that was up here talking, they got so much education. That's always so impressive to me to think of going through that much school. And it's very valuable. But when you put us both together, then we're extremely valuable. Because you can't really read what it's like in a book to go through addiction and incarceration and the unrealistic expectations that it takes to re-enter society and then maintain your sobriety. So March of 19 is really when the Arkansas model was launched, and that's when I went through it. Now, you got Bonnie Stribling back here and Les Cup. They were involved in it before. I think it originally came in 17. I should know this. I think it was 17. Trainer of Trainers got together in 18. And then these folks got together with the Appalachian Consulting Group, and they designed the Arkansas model. And I went through the first class taught by Bonnie and Monty. And ever since then, it has just continued to grow. And what we're here, I'm actually right there. You can barely see me. But this is whenever the governor signed the Bill 1433. And I believe the bill was referring to allowing people with drug background or criminal background with drugs to work in the state positions. So this is some of the objectives of the DHS Recovery Unit, which is run by Jimmy McGill, is to advance the division's commitment to and support of recovery for Arkansas, serve as a dedicated team employed by DHS with a deep understanding of recovery to provide insight on policies, programs, and services to those in or seeking recovery, and to manage the state's recovery projects, develop, evaluate, implement, and improve DHS recovery programs, and they do a great job at it. So another thing, I can't tell you off the top of my head when peer support actually started in other states, but we weren't the first to get it. But we were the first to develop this model, and now this model is being taken nationally. So you have your core level peers in other states, but we designed a model that had 3 levels. The first level, what it takes to even get into training is you have to be 18 years old, at least 2 years of complete abstinence from any minor mood-altering substances. You can't have any active warrants. You can't have any violent charges. You can't have any sex offenses. And if you got all that, then you fill out the application, and that qualifies you to go through the training. You go through the training, which is 30 hours, and you select a supervisor. You'll receive a PIT letter. From there, you have 500 work experience hours or volunteer hours that you have to do. You have an additional 16 hours of continuing education, and you have 25 direct supervision hours that you have to complete that can be done by group or individually, and then that qualifies you to take the test and become a certified peer specialist. You take the test, you become certified, then you can go on to the advanced peer. Pretty much the same requirements, except it's not 30 hours, it's 18, 17 additional continuing education hours. You still have your 500 work experience or volunteer. Well, at that point, you're probably working, so it's not volunteer. And then 25 direct supervision. You take the test, you get certified, you can go on to the hardest one. I actually have to look at this one. So I know it's 40 hours total. This requires you to have been working in the field as an advanced peer, regular peer, for 1 to 2 years, 3 years of complete abstinence, and then 24 hours of the class is 24 hours. You got 40 total to do, so 500 work experience, and this comes with a ton of supervision. You have 250 hours of supervised work experience, 250 hours providing supervision, 50 of those hours which must take place under the supervision of a more experienced peer supervisor. And then you have requirements for recertification, which no matter what level you're on requires 6 hours of ethics. This is the pay grade. I remember when I started, the pay grade wasn't near on the core level. I think I was the lowest paid person in the state, and that was okay because I was gaining a lot of experience, but I remember working really hard. But you can see, I've seen people on the core level get as much as 41 as a PIT. That job didn't really come with a lot of benefits. We start our peers at Exodus at 35. You see you're kind of between 40 and 45 at the advanced level and 45 to 50 at the supervisor level. And this is good money. This is good money, especially when you got 14 felony convictions. You know what I mean? Not everybody has a background, by the way. Just the majority of people, if you've been in the grips of addiction, I was 30 years old before I started using drugs, the end result was the same. Like I always say that I stopped by prison on my way to death, and it was the best thing that ever happened to me. So there's the pay ladder on the 3 levels. And this is the grants that fund all of the programs that's run by the state. Some of you probably are familiar with them. You got the block grant, the RAPA money, COVID relief funds. I started off under STR at Lone Oak, and then you got SOR 1, 2, and 3. And I can't tell you what all those total, but it's a lot of money. So these are some of the state contracts that this money pays for. There's me and Jimmy and my first class at Lone Oak. So there was just a few programs, Bonnie. One there, it was like you were working at DYS, and I took this. I was in the core training when I heard about this position. And I don't think I'd ever been to Lone Oak for anything. I've been through Cabot, but I definitely never been to the sheriff's office. All my trouble came right here in Pulaski County. But I went out there, and I didn't have a whole lot of confidence about myself at the time. You know, I'd been through the grips of addiction. I've been through incarceration. I was extremely successful in my 20s, but it felt like it was so out of reach at this point. All I do was I had a lot of drive and I had a lot of passion, and I was going to make this work. I wasn't sure how, but I was going to make it work. I was fresh out of training. I was still trying to understand what it meant to be a peer specialist, and we had a unit there that they had dedicated in this little 150-person jail, and it was G unit, and that was my office. Well, I take that back. I did have an office. Les, you seen it? It was actually a chemical closet. And they finally had some of the trustees get that out, and then it had a couple buckets as my chairs. You know, and they were like, hey, you got to set your desk up against the wall where you're not sitting across from anybody because it makes you look like a power roll. And I'm like, yeah, I don't even have a desk, so we don't have to worry about that. But I went back there, and it was a lot to get started. I'm going to tell you why. I interviewed with a judge named Sandy Huckabee, and he a great guy, really good guy, and he was also the drug court judge. And I interviewed with Sheriff Staley, and Sheriff Staley was like the youngest sheriff in the state at the time, and he's just a small town sheriff like you'd picture, you know, big, kind of aggressive, but smiles like a politician, but you could tell he knows his stuff. And he just looked at me and smiled, and he says, I'm going to remain a skeptic. Because if this don't work, I could say, I told you so. Fair enough. So we developed this program, and we didn't really know what it was. We didn't know what it was at all. We were setting up this unit. You walked in, it had like recovery literature on the wall, and like I would bring them coffee, and like they had a DVD player. It was like a really privileged unit, but we were trying to decide what this program looked like, and what it ended up looking like was 6 hours of class a day. So I was out there like a Harvard professor, not letting anybody talk. I was doing all the talking because I knew everything, right? I was learning. I was real green, didn't know what I was doing. But I started, you know, Jimmy kept working with me. We talked. It was a 30-minute drive for me every morning, and we would just talk about how we were going to develop this. And it was really difficult to get everybody on board. But here was the problem. Some of these guys had been through there 30 plus times. And, you know, the stigmatizing language they would use would be, this is a frequent flyer, this person's not ready. And I needed these guys to be in this program long enough to get enough information to take outside those walls to try something different. So Jimmy and I, we got together and we put together these 3 phases. And it was like the first phase, we're going to hammer out classes. You're not going to be a trustee. You're going to be focused in here because, I mean, you're a trustee, you go out in the halls, you go down you get some drugs. It's like you're putting them back to get sick where they got sick. And so the next, from 30 to 60, I was kind of putting you in a leadership role. You were helping me facilitate some of these classes. And then the final 3rd phase of the inside portion of the jail was you could be a trustee. You still had to attend 3 hours of class. You helped with leadership. And then someone's going to push back at $57 a day saying we don't want to house these people this long. And we said, but if we give this a try, you might not house them anymore. And so we got the buy-in from 2 of the 3 judges. The 3rd one never liked me, I don't think. That's okay. But we got the buy-in. And so what ended up happening is not only was this a drug program, it became an alternative sentencing plan. So instead of these guys going to prison for their 3rd, 4th, 5th, 6th, whatever trip it was, they got 6 years probation. But they got sentenced to the program because our program, it's voluntary to receive services from us. You sign into services with me when you want, you sign out when you want. But if you volunteered for this program, but once you were sentenced to it, then you were bound by your sentencing order. So it was a year-long program. You did 90 to 120 days inside, and then you did the rest outside. Let me pull out my other thing here. They said Elvis even used a cheat sheet, so here's the numbers. So of the 16 men that I had, 12 of them sustained recovery. 60% of the men had never been offered treatment and were not allowed or were not aware of the disease of addiction or that recovery was even an option. 40% of the men had been in a traditional treatment center more than once. 60% of the men chose to go into recovery housing upon their release. 85% had been incarcerated at the same jail more than 3 times for over 30 days at a time. The success rate was 74%. The measures of success that we measured was sustained recovery, being able to pass drug tests, employment, housing, family engagement, community engagement. And then the money that was saved, we did $56 per day. So $56 per day to house 1 inmate. We had 12 men over the past year that had not reoffended with their normal timeline for rearrest after release is 3 days to 6 months. So if you take $56 per day times 12, that's $672. $672 times 30 equals $20,106 per month. You multiply that times 12, $241,920 saved off 12 men. Not bad, huh? Well, they thought it was good too, and that's why they allowed these other programs to start. We got Lawrence County, which is up around where my wife's from. You have Garland County, Sebastian, Saline, the Division of Youth Services. Again, Bonnie's the supervisor. That's where my wife works with Bonnie. Blakely's here somewhere. Oh, there you are, Blakely. And then Pulaski County. And I also like to mention that Garland County was one of the first ones that was a grant-funded position that the Quorum Court decided was effective enough that they rolled that into a permanent position. Then the next program, this is a really unique program. We actually have this at Exodus where I work, but it was the overdose response teams. Lona also adopted that. You had Hot Springs, Johnson County, you got Izard County, which is represented with Josh and Ashley here, which is really more than Izard County because you're kind of over 5 counties, right? You got Searcy, which is the 6th central, and then of course ours in Jefferson County. And what this overdose response team looks like is this big grant went out, I think it was called COPE 2. I can't recall all the acronyms, what they stand for, but what happens is if there's an overdose call, the detective gets the call as well as the peer specialist that's paired up with that investigator. They both show up on the scene, and rather than go to jail, they try to get them into treatment. Again, you can't arrest your way out of this situation. We got 932,000 people that have died from overdoses nationwide. We got to try something different. We had, 681 in 20 to 21. here in Arkansas alone, a fatal overdose. And this program it's been really good. It's been, again, it's a unique relationship between, an ex-addict and an overdose person. What am I trying to say? Overdose investigator. There we go. This is the numbers that they've gotten out of the overdose response teams. They've had a total of 12,622 contacts, 202 overdoses, 200 follow-ups, 28 Narcan training, and persons referred to treatment was 407. Those are old numbers. Josh, how many people have you actually gotten into treatment alone? That's just them alone on their one grant. Yeah. So clearly a very effective partnership here. And the Narcan trainings, I think all of us are kind of on rotation. We do those every other week, it seems like. Okay, the hospital and emergency department peers. You've seen Sling County earlier. Samantha Ellis was here. She is actually the peer for the Bradley County, which is Warren, Sling County, UMS, Jefferson County. It's the same concept basically, except for they're not actually paired up with an investigator. Whenever they come into the hospital with an overdose, the peer specialist makes contact with them if they're willing to receive services from a peer specialist. And in return, they help to direct them toward treatment, detox, and a pathway to recovery. This is the next big thing that has really happened in the state. I call it a big thing because we're a part of it. And that's the Recovery Community Organization, or RCOs. All four of these kind of launched at the same time. You got Wolf Street Foundation here in Little Rock. You got Pearl that used to be led by Ashley LeHue right here. Exodus, which is us, and then you got Shlenda Woolbride and Divine Intervention, which is in Jonesboro. And these are great. An RCO is completely led and governed by peer specialists, and 51% of your board is in recovery. It's a great tool for people looking for recovery services. Exodus alone, we have multiple things that fall under just our RCO. We run we run a program in Fayetteville's prison, West Memphis's prison, Little Rock's RPF unit. We're going into Malvern as of this week. We have Jefferson County Jail. We have the Jefferson County Juvenile System. We have our police peer partnership. And then we have two other peers that service about 30 memorandums of understandings between Pulaski County and Jefferson County, as well as any self or community referrals. These people pump out some numbers here. You can come at any time. You don't have to have an appointment. Our door's open. You come there, you sign in the services with us. We find out what it is you're looking for, and we start connecting you. My approach used to be the fixer. That's not the approach you take because it doesn't work. Somebody said earlier about planting a seed, and that's what we teach when we take you through these trainings now. We don't have the ability to make anybody do anything. We just keep planting those seeds. You come to me when I provided direct services, and I'm going to talk to you. We're going to do a little motivational interview, and we're going to find out what it is you're looking for, and I'm going to provide you as many options as I can, and what you do with that is on you. One of the worst things that I was bad about was I used to say I should have wore a cape because I was Mr. Recovery. I would help anybody at any time. Just call me, knock on my door. But it didn't go over too well. You can't take that approach because, somebody calls me now and says, "Hey, I think I need treatment." I'll say, "Why? Why do you think you need treatment?" You start to say, "Okay, hey, yeah." But you can't do that because you got to have skin in the game. Because a lot of times you find out that my girlfriend and you got in a fight, she says, "Well, where she's going to stay with me is if I go to treatment." That's probably not a very good reason you're not going to stay. People got to have their own skin in the game. They have to. You can't get ahead of people. We got to walk alongside of people. And it comes with experience. It comes with, paying a lot of attention to your supervisor and learning how to do this the right way. I've done it the wrong way, so I've gotten better at doing it the right way. Okay, the next thing that is big here is this faith-based recovery. Why do you think faith-based recovery is part of this? Overdoses in parking lots. Okay. Well, also here, so this was a pretty big grant. I know I haven't been given numbers on the other ones. I think this one, each one of these facilities got $500,000. And basically how it looks in Arkansas, that's the only place I've ever worked as a peer specialist, but when somebody calls you and they need treatment, this is the way the conversation's going to go. You got insurance? I got Medicaid. Medicaid ain't paying for anything. So you're either got insurance, and it's either going to be some insurance that's going to pay for some stuff, or you're going to have the conversation about a copay and a deductible. And then, as Sean said, they may allow a payment plan for you. So you got that option, or you're going to fall in the catchment area, right? They're going to base that off what's on your ID if you got one. And then hopefully there's a bed, and hopefully there's still state funds. These are all challenges. You got your faith-based places. They're everywhere. There's a lot of these faith-based places, and they'll take you, providing you don't have certain charges. Typically, they're going to want you to work. You can't be on any really heavy psych meds. You can't be on Suboxone, like we were talking about earlier. There's requirements to get in these, but they'll take you. And so a lot of times this may be your only option. But these are good programs. I will tell you one of the things, Sozo is really, they're doing a lot. They're all good in their own way. Sozo is one, though, that's kind of got some ACC funding, as well as we talked about Bonnie Safe Haven, right? Safe Haven's got some ACC funding, so you can kind of go there if you've got a record or if you're currently on parole. But they're all good. ARM 180's down in DeWitt, Sozo's in Hot Springs, Hoover's in Little Rock, Dots is in Searcy. And that's kind of a blend of both men and women facilities there. I don't think all of them are co-ed, but some of them are kind of, they're not, Sean? Sozo's male. Which is huge. You find someone that take women and children. Okay, the next thing is really cool. It's called the Inside Out program. And what they're doing is they're actually going into a prison. It's in Pine Bluff, and they're taking people, and this is a little bit different than the training we're talking about. Like I said, you go through the training here, you spend 5 days in it, you get your 30 hours, and then you pursue all your time outside of there. This is all done inside. So they take you through the training, and they take you through the supervision and everything, and when you leave there certified. Is that right, Bonnie? Leave there certified, and then if you go to a halfway house or something, you can work for them right there. So they're setting you up to come out, ready to go, and I think the numbers is 20 a quarter. So that's 80 people a year. And then the reentry centers, one of the ones that sticks out in my mind is Hidden Creek. It's over there off of Markham and kind of by Markham and Shackleford. And I don't know how many people they have over there. It's 40 to 60, I think. Do you know, Les? It's quite a few people, but they just got a pretty good-sized grant that allowed them to hire a peer supervisor as well as 2 peer specialists. I think they're hiring another male and a female. And then also Safe Haven is considered reentry. They have, because they got their ACC funding. Freshly renewed, yeah. Freshly renewed, that's off baseline. They've got inpatient, outpatient, and then they got a ton of chem-free beds, like 130-something beds, I think. Okay, this moves us into the Arkansas Peer Advisory Committee. Bonnie, I think you're part of starting this. I've been in it since the beginning. And a lot of these programs, it's always funny how we get started, because we kind of get started and then we're like, okay, yeah, what are we exactly? And so we just keep developing. And basically the Arkansas Peer Advisory Committee, as Jimmy would say, he's not the smartest person, so he relies on us to help provide information. And we kind of, we went through a lot of challenges, everybody did. COVID kind of came through there, and we used to, what I remember some of our first, so the first things we did with APEC was we would review the applications that were submitted by people. We would sit up there at Wolf Street, and everybody get 5, and we would kind of go through them, and we will vet the applications, and so that's kind of how we got started. And then it kind of was like just kind of leaderless for a little bit, and then we brought it back in. Jimmy stepped back up and he took over as the director or the chairman, whatever you want to say, for the Arkansas Peer Advisory Committee. And then we really structured it. So now we have 5 regions, and we have 15 regional seat holders, 3 per region. And as you can see here, let's see here, certified. You got to be a certified peer to be on the be a regional seat holder with extensive knowledge and experience regarding the roles of peer specialists and the work they do. APEC's primary responsibility is to advise the DHS recovery unit on best peer recovery practices and offer guidance to strengthen the peer recovery workforce across the state. Another thing is, and Ashley, you can attest to this, is everything has really been Central Arkansas. It's been really heavy always towards Central Arkansas. That's where everybody was. That's where most of these programs started. And then so you had like Ashley, she was coming down and stuff, but it's kind of like what works in Casey's house is not going to work in a house in Jefferson County, right? And that's how we started to view this. And I see so many people do this. We come up with such good ideas because this is what works here. And we skip assessments, we skip all the strategic plan steps, and we go straight to implementation of it. And it doesn't work. I always tell people, if you want to know what a community needs, why don't you just go ask them? That's the easiest way to figure it out. But we needed representation other than Pulaski County. And so that's why it got designed like this. And what we decided to do under this is have subcommittees. And a subcommittee person can be a PIT. You don't have to be certified to be on the subcommittee. And of course, my region is Region 3. It's Tawana, Sean, and myself. Of course, I think he's trying to leave us because he's going to work for the state. But we have the biggest pick of people because at one point there was like 300 and maybe 80-something people had gone through. There were so many people that went through the training in Pulaski County that we actually had shut it down for a little bit. Because we want representation in all 75 counties. That's always been the goal. We want peer specialists in all 75 counties, and we want representation in all 75 counties. So each region has a subcommittee that has multiple people on it. Pulaski, I don't know how many we've got. We've got a lot. We've got a Facebook page, and we've still got people signing up, calling us all the time. And we want them. We want as many people as possible because we want to know what's going on in these counties, what we can do better. All right. Any questions about the process or peer support or programs or anything? Kim?
I was going to ask, do you have peers currently in each of the counties, and how could someone get in touch with peers in those counties?
That's a great question. So there are some counties that still that doesn't have peers in them, like you get down in southeast Arkansas or too far along the Delta, but there's some close by. But here's how you can find a peer in your area is you go to the AR Take Back page, and you can click on the county, and it will show you the peers that are in that county. It should show you what level they are as well. Like if it says core training only, that means they went through the training, they never got a supervisor. Of course, the rest, they're certified, whatever, and it should have email and a phone number. And this is what we do because like a lot of these prison programs that we're in, that you got to continue the care outside of these. So I want to sit down with these people, or I want to have my peer specialist sit down with these people and find out where they're going and at least give them the contact information for people in that area that can connect them to recovery resources, because that's when the work really starts. And so that's a great question. You go to that AR Take Back, click on that county, and it will show, and they try to keep that updated. Okay, so then the next thing that we started and weren't sure about. Oh, I'm sorry. Oh, go ahead, Sean.
I was just saying, do y'all not believe in the methodology by something? Because we're hiring for a peer specialist. You can't find one. It's PhD behavior improvement or whatever.
Yeah. Do we believe in it? We support all pathways to recovery. Yeah.
It's been advertised for.
Yeah. No, we support all pathways.
Some of my patients are really to do this. But they're recovering, and I'm just saying that they've been on it 12 years.
Yeah.
So, I think that would be really good, but we posted it, and we have no.
Let's get
And
together.
that's the name of it. It is a peer recovery specialist, and
Yeah.
there's nobody who.
Let's get together after this meeting.
Yeah.
I'll get the information about the job posting. We'll put it on the peer Facebook page.
Okay.
So we'll be
All right, thank you.
But to answer your question, yes, we support all pathways to recovery. I got cleaned in NA. I led a Celebrate Recovery ministry with my wife for years. I'm a deacon at the church. That's just kind of my pathway. If you don't believe in God, that's perfectly fine with me. One of our emerging recovery values is to never push our personal recovery on anyone. We want to find out what works for you and support that. Now, as far as becoming a peer specialist, if you want to become a peer specialist and you're currently on Suboxone or you're your pathways medication assisted treatment, the requirement is you will have needed to have been on it for 2 years, and we get some documentation from your doctor proving that, and then you wouldn't have a problem going through the training. Sean?
One thing I'd like for you to do is, one of the challenges that we had when we started working for a treatment center was defining the peer role. Could you kind of maybe talk about what we don't do?
In a treatment setting?
Well, just what peers are not supposed to do.
Okay. Of course, Sean and my sponsor, who works in the treatment center, would ask me that question. So I think some of the challenges that people face when we first got started with this is people weren't sure what we did. They didn't know. And so they got a grant to hire a peer specialist, and then there's, what's that look like? So come over here, and I'm going to need you to help me drug test these people, right? Stuff like that. And drug testing is not an ethical violation for us, but since everything we do is about mutuality, like when I sit down with you, you're not better than me and I'm not better than you. But if I start drug testing you, then it kind of seems like I'm in a power position, and it's called being co-opted. And I don't think people necessarily meant to co-opt people. I just think that they weren't real clear on what the role of a peer specialist was. And so as supervisors, I have no problem going out and sitting down and talking to the people about what services look like. Because like I said, everything we do is going to keep us on an equal playing field. Does that answer your question? You want me to go a little more? Do you have something in particular you want to mention? Because please do if you do.
Actually, I do.
Please do. Mention.
I just want to make the point that we are not there to replace a therapist or a social worker or a counselor. That's outside of our scope of practice.
Right. Yes, and that's a good point too. There's stigma, y'all. There's stigma that follows me. Look, I've been to prison twice. I was a meth opioid addict. Some people don't know that by looking at me because I don't really look the part of that, but that's my story. That's what it is. I understand people that have never been caught in the grips of addiction, which I find out the more people that I talk to are a lot more familiar with it than they put off. My brother was in addiction. I struggled with alcohol, whatever. And so the stigma that follows us, people were reluctant. And I get it. You know, people waited for us to kind of fail. And there are people that return to use. You know, it happens. But one thing that I can tell you is we do remain within our scope of practice. And I'm going to tell you something. I don't try to replace anybody. I try to put us all in the same toolbox, because the people that I've seen do the best that I've provided services for have a peer specialist, they're seeing a therapist, they got a sponsor, they're living in kin-free housing. And the people that put all those things together, those are the people that I see really knock it out of the park. And so definitely there to collaborate, and definitely not replace. We need everybody in this. Addiction is a serious disease, and I don't think you can have enough players in the game. Any other questions? Yes, ma'am.
So in that role, do you guys help them in any way with housing and transportation? These kind of things that will keep them moving forward in life. So, you know, housing is very important, and, you know, different programs that are out there, you know, connected.
Absolutely. That's what we do. That's what we do. Now, not all facilities, see, a ride is always a huge barrier. At Exodus, we provide services. It comes with rides. Now, I tell people, like, a ride that I would give you, doctor, parole visit, you got court, and I'm going to help advocate for you in court, stuff like that. Now, I'm not going to come pick you up, take you to Burger King at 8 o'clock at night. One of the things I want to do is try to make people self-sufficient. So if you don't have a vehicle and you're in Little Rock, I'm going to work on getting you a bus pass, but I'm still going to help you with rides and stuff. I'm going to help try to get you on your feet. When I sit down with you, one of the first things I ask, do you have insurance? If not, I connect you to some insurance. Go and fill out that application, because if you've been out there in addiction, you need to go get checked up. You need to go see the doctor. You need to also have the option for treatment later on. I try to connect you to as many things as I can. I really just, based off the conversation, I have certain things that I always try to address right off the bat. Food insecurities, you know, people need food stamps. Most people need an ID and a birth certificate and a social to get a job. most people that go through the grips of serious addiction, they don't have any of this stuff. You know what I mean? And a lot of the people I've worked with have never even had a job other than maybe selling drugs, which we built resumes off that alone. Yeah. We try to do as much as we possibly can with staying in the scope of our practice. Any other questions? Bonnie?
I just want to run on that quickly is that we collaborate with our community members. So we may not be able to get them, it looks like case management. And when I first started, I thought this was like a case manager position, but it's different because we're not keeping a case file on people. We're just having that initial conversation. So we identify they need some job skills. So we have connections with Goodwill. We'll go send them over to Goodwill, right? And they build that there. They need help with housing, and so we may help them get those applications, but they fill it out, right? So it's like it's more about working together with our communities because a lot of us have used those resources. You know, some of us have gone through Goodwill ourselves, or we've been on food stamps ourselves, or I know what it's like to sit at the health department and wait for the WAC office. Like, I know what those things are like, and so I'll be there with them for them to do to get those resources that they need.
Yeah. And if you hear Jimmy McGill talk about it, he says, you knew where to get that dope, you knew where to get this, and you need to know how to get somebody an ID with minimal documents. You know, and it's what it is. We just used our lived experience of what it took, because it wasn't easy. It's not easy to get back on your feet. But if you got somebody that can help you navigate it, it makes it a lot easier. And it's just like they were saying earlier, the lady this morning, she said, how do you eat an elephant? One bite at a time. I get out of jail. I have nowhere to go. I don't want to go back to my house because I'm third generation dope cook and everybody there is getting high. I've never really had a job. I don't know what it's like to be professional. I'm from a small county. I don't know how to operate this bus route. I'm really terrified. I'm not afraid in the streets. I'm not afraid in prison, but I'm terrified to try to stay out here and live day by day sober because I've never done it. That's where we come in. We try to bridge that gap. And a good peer specialist has the resources. And even if you just don't know them off the top of your head, we're pretty close connected. We have a peer recovery page that you could post a question on there and it will get answered quickly. Hey, we need somebody said something about Kirby, Arkansas today. Like, I can't even picture where Kirby is, but I guarantee someone said, well, there's nothing there, but there's somebody right next door, you know. Okay, yes, ma'am.
If somebody wanted to be a peer support specialist, where do they start? Okay,
so what you do right now, they're actually developing a website, but you go to www.ar.gov/recovery, and it takes you, it says like flow page, and the first thing you'll see at the top says, would you like a career in recovery? And you click on that. We were talking about this earlier. I'm an insurance guy, and I just remember how much it paid to go through all that. All you have to do at that point is fill out that application, meet those requirements, pay for a background check, and provide a GED or high school diploma. And that's it. There's no application fee or anything. And then, like, even, we were talking about this earlier, even the supervision we provide for you is covered. The test is covered. The certification is covered. All you got to do is pay for the renewal of it. It's the cheapest way I've ever seen to get credentialed. Kim, did you have a question?
I wonder if you could talk a little bit. You had a slide that showed some of the health systems you were working with in primary care clinics. If you could talk just a little bit about the role of the peer specialist in primary care and how primary care can access that.
Okay, so let me back up to that slide here. So I don't really know that that these are paired up with actual primary care. These are more emergency department peers. And so, like I said, these people are really just, they're officed at the hospital, and as these people are coming in from overdoses, they just try to connect them right then and there. We actually had one that's not on here anymore, and the way that the process was for us, we had actually a camera crew come over. One of our peer specialists was an overdose survivor, and he just kind of told who he was, a little bit about his story, and they just kind of said, they would show these people the video. One of the things, if you remember Dr. Mancino talking earlier, all the stuff that they go through whenever they're going through that withdrawal after being hit with Narcan, it's really difficult to talk to people at first, because they're immediately in withdrawal and they're going through all that pain and stuff. But that's what the people essentially are there for. except for the mobile unit, and I believe that's Dr. Martin. Is that right? And what do they do, Bonnie? They just kind of go out on the scene, right? Or they go out into the or into the areas where there's not a doctor and try to help out that way.
So I work for Unity Health.
Okay, there you go.
And I'm in the behavioral health unit. So I work alongside the social workers and the doctors, and I also get called to the emergency room, our detox center, and I also go out to other clinics, counseling associations, different things like that. And I work with the community. So I'm the only peer for Jackson County right now. So I also go to the jail, and so I run a lot of marketing of the hospital. So she'll introduce me to different places, like yesterday we went to Mid-South. Another one I didn't get to meet them though, but I just get out there and I introduce myself so they can use me as a reference. That's awesome.
Oh, there's Samantha back there. What do you do at your Samantha?
Hospital, but we also have a rural health clinic, so we get to do both. And so what it looks like in there is kind of like it does at a hospital. People come in, and a lot of times they're coming in for issues that they think they have, which they do have that issue, but a lot of times it's related to drug issues or alcohol issues, things like that. But sometimes they request it, sometimes it's just different. It's just like a hospital, basically. It's just a doctor.
Bonnie?
I think that one thing we can consider, if you don't, you can reach out to the RCOs that are in your area, because they have hired peer staff, and you can build that relationship with the RCO, and those peers can go out to the primary care clinic and work with them as kind of what looks like a contracted worker in a sense, because you may not have the ability to sit there for 40 hours a week and maybe be used once or twice a day, but you can reach out to the RCO or to the community organization that has peers, or the behavioral health clinic, whatever, and they can come in and work with people, maybe once a week or twice a week, facilitate a group, whatever you think that would work for your primary care clinic. And I know that Dr. Martin at the primary care clinic, she has walk-in, she does addiction medicine. If you got, is Dr. Martin's clinic in the room at all? Okay. So they're in Russellville, but they have a lot of locations. But they're building a peer center behind them. But they have peers on staff, but they're also working in the community with other agencies that need peers. So it kind of becomes this more collaborative community thing.
And I love what Bonnie said about connect the RCO in your area, because every RCO's got a peer supervisor like myself, and we're gonna know the most about anything that involves peers. If we don't know, we're gonna contact some other supervisors and we're gonna get it figured out. That's a great start, is to contact the RCO in that area and let them help advocate or be a change agent for you. Any other questions? Okay. Let's go back here to, so again, when Kirk Lane was the drug director, he had talked to Jimmy about starting a recovery coalition. And so we started this recovery coalition, and it wasn't long after that Jimmy had stepped down and they voted me in as the director of this. And I took it without asking any questions, because I had no boundaries. And I didn't ask what kind of commitment or what it looked like or anything. I just go, yeah, I can figure it out. And so it took me a while to figure it out. But just to give you a little background on this, so this coalition was started. And I remember, Jimmy back then, he's got a big following, so he was getting people coming in, and I think there was 60 people in our first meeting at the state police headquarters. And we had lawyers, we had people from all walks of life in there, and we're in this big square, Les, you're there, and we're just kind of going around talking about what we're doing within our agency or whatever. And then we decided we're going to put together a mission and a vision and a purpose. And we kept this mission. It says to expand recovery services for substance use throughout the state of Arkansas, and to develop, implement, and evaluate statewide efforts, and to broaden recovery and awareness. And of course, APART stands for Arkansas Peers Achieving Recovery Together. And I kind of put that website down there. We were kind of piggybacked onto that website. There's kind of been some changes on there. A lot of the information we had on there is outdated. We're in the process of actually developing our own website. But it was also we used it as a resource page. But we had all these people come in, and we were trying to figure out what we were. And that was in 2019. And then COVID hit. And as it started to hit, we couldn't meet at the state police headquarters, and then we're meeting at the DHS building, or Department of Health building, and then it got shut down. And what happened is we went to Zoom, and that's when Zoom was kind of new. It was really difficult to meet because back then nobody knew how to work it, and the connections were bad, and people wouldn't be muted and be in their cars. It was just really difficult. And so here we are. We're going to figure out what is this coalition and what does it look like. And we got together and we brainstormed and we put together these talking points. And I'm just going to read some of them. One of them was we were going to find out recovery programs in all 75 counties. MAC clinics, detox centers, halfway houses, Kim-free, transitional houses, meeting locations, AA, NA, CR, just whatever. Information about peer recovery specialists, like we were talking about. Back then, they didn't have the website you could go to and locate peer specialists. Information about employment or unemployment, who will hire people with backgrounds. Resume building, how to conduct, people that could help conduct mock interviews, role play for upcoming job interviews, services for veterans, SNAP benefits. We were just trying to figure out what was available in all 75 counties. So we come up with that and nothing happened. We would meet and we would expect all this great information to be there. And I wasn't providing good leadership because I wasn't really aware of what we were trying to do myself. And so we finally broke it down into 5 work groups. And at this point we were down to like 10 members. And we broke it down into 5 work groups, and it was education, recovery services, outreach, communication and marketing, and the youth. And we waited, and the next meeting nobody came with any information. And so I said, okay, where's the light bulb not coming on at? And it had to start with me, and we have really good technical assistance out of the Office of the Drug Director. I wish she was here. Sharon Mims, we call her the pit boss. She is great. She's been dealing with Coalition since 1996, and she's really, brought to my attention how to make this work. And what we did was we just kept simplifying it, and all some people started saying, man, I can do this. And so what we did was we didn't say, okay, let's do this in Arkansas. We said, let's do this in Hot Spring County, Malvern. It's a very small county. Let's figure out what's there. And what we're mostly hearing is there's nothing. And that's what we needed to hear. Now we know there's gaps in services in these counties. So we started there in Hot Spring County, and we started to branch out. We started doing the Central Arkansas, finding out the same stuff I just talked about when we were brainstorming. And then I think Jimmy had put me in touch with Jenny. And I got this call, and I remember I was leaving the gym, and I got this call. I recognized this number, and I answered, and it was Jenny. And we started talking about what Kim and them had going on, and we had a great conversation. I think it was about 2 hours. I remember pulling up my driveway, and I was just sitting there talking to her, and I was thinking, man, this is great. For me, I'm thinking, thank you, God. You done sent me some good people here. And so we got in touch with, I got in touch with Sharon, and we talked about partnering with them. And this is the 10 counties we decided to target. As you can see, they're all kind of there together except Sevier. It's kind of down south. So we can sort of this consortium partnership, and we wanted to target vulnerable populations, find the gaps and barriers for people with substance use disorders. And so we targeted these 10 counties. I need to quit leaving this clicker over here. And then we talked to Kim, and what we decided to do was they were going to allow us to take on some outreach specialists. And we said, okay, based off the hours that we had available, when you broke it down per week, I was thinking it's going to take a highly motivated, structured individual that's familiar with these areas to be able to get this done in this amount of time. So what we decided to do was get an outreach specialist and also have APART back it. And so Josh, the guy that I mentioned earlier, we brought Josh on first, and we struggled a little bit with how we were going to go about targeting these 10 counties, and we had some conversations about it, and we talked with Kim and Jenny, and we looked at our work plan, and we just kind of kept narrowing it down to figure out what was going to work. And we decided that we were going to target one of the things that we were going to do is we were going to find out where people go that are struggling and need help in a small county, and that's usually always a church. That's what we found out. Here you come to an RCO, but a lot of people go to these churches, and a lot of these churches have food pantries, and so that's one of the ways we decided how are we going to connect people to peer specialists, and we targeted the food pantries. And I'm really just going to bring Josh up here and let you tell what you've been doing with that. So come on up, Josh.
Okay, so I'm Josh. I'm a peer specialist. I'm actually a advanced peer specialist in training, but I work for APART. I'm an outreach specialist. Ashley is the other. But I think one of the things about being a peer is my lived experience is one of my best resources. So where I've been is where I go to help people, and food pantries is one of the things that I use a lot in my addiction. We called it working the churches, working the town, and I think maybe if we had something like this back then, I might have gotten clean a little earlier. But yeah. We've been putting cards in there. It's got mine and Casey's name and our number on it. It's got a little pitch on there, and it gives them an opportunity when they go to get free food. Because if you've ever been there like me, when you go get free food, you eat it. It hardly ever actually goes to the kids because they eat at school and stuff. But we want to have them an opportunity in their house while they're in there. Maybe they're alone and they can read that card, and it might show them some hope. And they might say, you know what? I'm going to call this number because they can't see me. They don't know me. I'm going to call. They can call us anonymously, and we'll be able to offer them hope on the phone. And hopefully they'll say, can you come meet me? Can you come talk to me? So we can go offer them help where they're at. Like we were talking about transportation. I have transportation. The company I work for provides it. I also have my own transportation. So we have many ways to go pick them up, to counsel them, to get them admitted, to do an assessment on them, to get them an interview with the treatment center, and actually to transport them there. And while we're doing that, we can talk to their family. We can help them get resources while they're be gone, give them all of the information they need. So I just think it's a wonderful opportunity to be able to help people. I primarily work with law enforcement, so this is after arrest. I think it's awesome we can get to them hopefully before they get arrested, before they even have any criminal justice involvement, because that kind of complicates everything once you get arrested. So that's what I got.
Thank you, Josh. Appreciate it. And you can go ahead and hit that to Ashley, because I'm going to have her come up here. The next thing that we are working with Adilynn on was the implementing the naloxone drop boxes. Of course, y'all have heard about all the opioid issues we've had and the amount of overdoses we've had. So this is a great new program. Want to come up and talk about that, Ashley?
So my name is Ashley Sanders. I'm also a peer recovery specialist for the Israel County Sheriff's Department. And working with APART, I have just been reaching out to the 10 targeted counties, meeting with first responders and law enforcement, doing a small presentation about the naloxone box, trying to pick a location in the county where it would best benefit the community. We also have discussed 911 dispatch training, which Megan can elaborate on that a little further.
Thank you, Ashley. Hey everybody, my name is Megan Copeland. We have been speaking with Emergent Vital Solutions to find out what Chicago is doing for the naloxone opioid epidemic. The opioid epidemic, and they're putting nalox boxes in all public places. So we are trying to form a partnership where they will teach us the model they use to teach their 911 dispatchers how to respond in an overdose. So that's just an ongoing project that we have coming up. And while Ashley is out speaking to the counties, she's asking the sheriffs and the first responders if they have training for their 911 dispatchers, and we are hearing time by time again that they do not. So this is a huge gap, and we're hoping soon on the forefront that we'll be able to fill that gap.
Let's turn that on. So yeah, I was surprised when we talked to them as well, because they were saying that people know how to tell you how to administer an EpiPen, but not Narcan. So I love this. I wish I was out there with you guys blazing the trail, because I love doing stuff like that. But there's a lot of good stuff going on. Our partnership with Kim and Jenny has been great. It has really given us a lot of purpose for our coalition. I failed to mention that at one point I was playing the director, treasurer, and secretary, and those are not my strong points at all. So Megan has come in there, and she's really offered a lot of organization and helped out in a lot of ways. And now we're taking on memberships with that, like APAC, left and right. We get a couple calls a day now, and we want everybody on there. The other thing we're doing is we partnered with the CRDC prevention team for this Stop Stigma campaign. This is something that we had been working on. We have a coalition member, and I'm going to say her name. It's Paula Cunningham, and she has a son that had overdosed and passed away. I serve on her board with the Parker Gill Foundation, and she's great. We love her. And she came in when we were talking about making Stop Stigma videos, and we were trying to come up with what we were going to, do these videos from. We had our marketing guy in there, and she says, "I'm not who you say I am." And that has stuck with us. And so when we got asked to do this, we just jumped right on it. And so we designed, they designed this billboard, and this billboard is going to go up as of right now in 28 different counties. And so we have partnered with them to take on this Stop Stigma campaign, and we're just going to keep right on blazing the trail. What questions do you guys have for us? Yes, sir.
So you interview all these clients, right? And do you have an understanding of why we have a problem with drugs?
Trauma.
Yeah. A lot of people, there's various reasons. I was, my parents didn't, well, I'm sure that they did drugs or drink when they were young. I was never exposed to it growing up. I just remember my parents smoked cigarettes. I didn't experience any real childhood trauma. I had some uncles that were alcoholics, and I remember them at family functions just being drunk and getting on my nerves. Like, I never thought I would ever be an addict myself. For me, my dad had a heart transplant I lost my dad, excuse me. He had a heart transplant at 38, and he got addicted to Oxycontin. And I said no childhood trauma. I got shot as a child. That's probably some trauma, but it was an accident. But I remember getting shot on a Saturday, and Sunday I wasn't taking pain pills. But my dad was hooked on these because of the amount of medicine he was taking. It was like his muscles were deteriorating, his bones. My dad was ran 5 miles a day, was in really good shape. And when he didn't have this medicine, he couldn't get out of bed. I remember him just being there. I could hear him moaning. It was horrible. He'd be cramping up. And he was prescribed 60 milligrams in the morning of Oxycontin, 20 after lunch and 20 after dinner. That one prescription, it's a done deal in a month. You're hooked. My brother, scholarship football player, got in a car wreck. He starts abusing the pain pills. You see what I'm saying? And then lo and behold, here I am 30 years old, and I go from these prescription pills to get in a car accident. Now I'm on the opioid. It's like a generational curse. But so that's kind of what my story was. But from what I see mostly is the childhood trauma. And if you look at the ACE study, as well as several other studies, you'll see most everything relating to some type of childhood trauma, abuse, neglect, something. That's the most common thing I see. But I've also seen people get their wisdom teeth pulled out and get hooked on a script. Sports injuries. They just grew up in that atmosphere where that was the norm. People in their family got high. I've seen several reasons that people have been, hooked on drugs. But after they've been on it for a while, their belief system becomes shaped to that's what they think they're going to be. Whenever you're told you're going to be just like your daddy, and your whole life you get in trouble, and that validates everything you've been told, then you get to take a peer that steps in, and we try to crack that filter and say, hey, who says you got to be like that the rest of your life? So there's several reasons I've seen people get an addiction, but the most common is childhood trauma. What other questions? We still got some time.
So you guys just have the billboards for the Stop Stigma?
That's where we're at right now, but we're supposed to be taking on another region. I think we're going to go into 40 plus counties, and I think there's going to be some radio ads as well too, right?
There are, and there's opportunity for more things if any other areas would like to work with us.
Do you guys work with any of the schools? Like to go talk to the schools and especially the younger peer support?
We're doing that today, as a matter of fact. A lot of the DHS recovery unit, how many people are down there now, Bonnie?
6 people that work at the Division of Aging and Adult Behavioral Health Services, DABS.
And then we have 3 peer specialists that work with our youth at the Division of Youth Services, that's after they're incarcerated. So there's been some school districts that have reached out to the RCOs. There's 1 or 2 that have reached out here in Little Rock to Wolf Street Foundation, and they've brought some of their peer specialists now over to talk with students at the schools. Up in Northwest Arkansas, you have them reaching out to people, and it's really just networking is kind of the only way, and then we do that probably for free, just go out and talk with the kids if we need to. But I think the biggest thing that has to happen first is education about what it looks like to be in recovery and what's available. When we did a Narcan training with teachers at a conference, it was surprising how little teachers are, they don't have access to the information about education on the opioid epidemic and how they can be trained in Narcan. And there was a law that was just passed by Representative Shepherd that's going to be putting Narcan boxes in every public school. So all the teachers and nurses are going to be at least aware of or trained in Narcan across the state of Arkansas, which is really exciting. But that would also be a great avenue for peers to step in and do, any kind of peer group or, just general support and education.
Yeah. We're not opposed to doing more because, I have nephews that's in school, and when they tell me what these kids are doing these days, like, it's way different than what we were doing back then. We had another question back here. Okay, you right here and back here.
I actually have, the stop the stigma thing. I'm the parent of a recovering addict, and I think that stigma extends to the families. It's not just, and I'm saying that to say that, when we first understood that Michaela had a problem, it was very embarrassing. And I think that it probably kept us from really going in and getting the help we needed. We wanted to fix it first. We wanted to see if we could fix it first. And so I think that I just hope that if there's some way to include, I don't know what I'm saying, but to include the families and include somehow for that just to be the stigma.
I think that's great because, like you said, and that's on the recovery side of it, or whenever they're first getting an addiction. It never just affects the person using it; it goes through the whole family. But you're right, the stigma that follows it, it's horrible. And what happens, what I've seen, is people, especially in a lot of well-to-do families, they don't ask for help because they don't want to tarnish the family name. They end up dying. Like you've heard me talk about some success I've experienced a lot of loss in this business as well. And that's what I hate about stigma, is it stops people from wanting to ask for help because they don't want to be judged. And that's what I consider stigma, is straight judgment. Yes, ma'am.
On the billboards for the Stop Stigma campaign, what is that number? Who is that going to when you call that 1-800 number?
That's the crisis hotline.
Crisis hotline. Other questions? Yes, ma'am.
I know just from experience and knowing some of the peer recovery specialists that once they get someone into treatment, they kind of walk through with them and check in on them and they don't just drop them off at a treatment center and say, bye, see you in 6 months or a year. But after the treatment, after the rehab, is there a step like a transition house or something like what are the steps post?
Well, for whoever we're providing the services for, it's their decision, but it's, I would definitely encourage that be the next step, because you just, from being in recovery, I go at recovery the same way I did from the beginning. I'm never just going to be like, oh, I've arrived today, I'm good. I'm not, because complacency is what will put you back out there. But, when people go to treatment or something, they're in their 30 days, they come out you've been doing drugs for 15 years. You got mental health issues, you think 50, what's that do? That barely puts your foot flat. So yes, it's definitely encouraged, because you need to you got to keep continuing. I see so many people, when we're in jail, these jail, that's one of my favorite things is to run programs in jails. I love it, because people are they're set down, they know they're not leaving that day, and you're going to get them in there, and hopefully you'll get them honest, and they'll start telling you what's really going on, and then you'll know how to better help them. But what you always hear people say is that they're done. So now you tell me you're done, I'm going to say, what does that mean? Because a lot of people that are in jail, I'm done living this way. You got to figure out how you can keep that attitude hot when they cross that threshold, and now they've got the opportunity to go that way if they want to. Because so many people fell from the continuation of their recovery process. Bonnie?
Go off of that, I think one of the biggest differences between like clinicians and peers, there's a lot of differences, but one of the differences is the continuation of care. I think a lot of times when I worked in a treatment setting, after that peer had left the treatment center, most ethics would say that you have to cut contact. Yes. You're not going to check back in with them. But for a peer specialist, that's actually our strength, is that we want to stay connected with them as they leave, because that's part of our continuation with them, is to continue staying with them. We do have ethics, and we do have an ethics review committee, so those boundaries still are in place. We're not going to cross boundaries ethically, but we do want to stay in contact and work alongside them, so when they get into a transitional, which we can help them get into by giving them resources, and then stay with them as they get out. And that's a big difference. I think focusing on termination is something that we don't do. That's really up to the peer if they're ready to terminate services, but it's an ongoing relationship that can evolve over time. And that's a big difference, I think. And a lot of clinicians don't always understand. That's fine if they don't, but it's one thing that I always advocate for the role of a peer, is that we're allowed to stay in contact with them as they leave, which can be weird, because like, who's your pay source and how are you allowed to just pay for these services? But for us, it's really not focused on that. We're just trying to make sure that they stay clean or stay in recovery.
And I'm glad you mentioned that. That's true. That's one of the ways that we are able to stay so close with them, is that our ethics allows for that. Like, going to a recovery meeting can be intimidating when you don't know anybody. I can't tell you how many times I've been like, let's go, hop in, let's go over here. Which one you want to try? You want to go to AA? Let's go. I've taken people to the gym. We can really walk beside you and stay connected. And I don't know if I've mentioned this, but all of our services are currently right now, we don't charge for our services. You can come see us as long as you want to, as long as you need to. I've seen people for over 1.5 years providing direct services. I've seen them 3 times and never seen them again, and everything in between. What other questions? These are good questions. Well, if y'all have no more questions, here's my contact information. If you find that you have questions afterwards, feel free to reach out. If I can't answer the question, I will definitely try to point you in the right direction. And thanks for listening to me.